Good evening. We at Columbia Global Centers welcome you to this webinar, Caring for the Heart, Women's Health During COVID-19. I would now request Dr. Ravina Agarwal, Director, Columbia Global Centers, Mumbai, to please introduce our panelists and begin the session. Dr. Agarwal.
Hello to everybody. On behalf of the network of 9 Columbia Global Centers worldwide, I, Ravina Agarwal, Director of the Mumbai Center for the South Asian region, welcome you to this very important webinar, Caring for the Heart, Women's Health During COVID-19. The Columbia Global Centers were founded as a presidential initiative more than a decade ago with the mission of supporting research and education and building partnerships between Columbia University and global communities to enhance understanding, address global challenges, and advance knowledge. For this webinar, we are partnering with the Women Creating Change program at the Center for the Study of Social Difference at Columbia University. This program engages distinguished feminist scholars from diverse fields throughout Columbia University who focus on contemporary global problems affecting women and on the role women play in addressing these problems. My team and I also can speak for our Executive Vice President of the Global Centers, Professor Safwan Masri, all of us would like to say a big thank you to Anne Kaplan, who is the chair of the Leadership Council of the Women Creating Change initiative, and also to the Executive Director, Catherine Lasota, for all their support in making this happen. In the US and in India, cardiovascular disease is the leading cause of death in women. In India, out of more than 10 million deaths annually, almost 2 million are due to diseases of the circulatory system, of which 40% are women's. The epidemiological transition in India in the past 2 decades has been dramatic. In a short time frame, the predominant epidemiological characteristics have transitioned from infectious diseases, diseases of undernutrition, malnutrition, and maternal and childhood diseases, to non-communicable diseases. And despite cardiovascular disease accounting for more deaths in women, many remain unaware of their personal risk for heart disease and stroke. Since the novel coronavirus took hold of the country in March, many healthcare professionals are concerned that the number of people, especially women, seeking care for heart diseases has significantly reduced. The coronavirus pandemic has given new urgency to many of the challenges that women have long been confronting, such as balancing multiple responsibilities, working without a safety net, suffering from lack of short and long-term care support, and experiencing increasing levels of stress and anxiety. Despite a global understanding that the presentation, treatments, and outcome of cardiovascular diseases are known to be different between men and women, women continue to be underdiagnosed, undertreated, undersupported, and under-researched. In today's webinar, we will be looking at various approaches that can be undertaken to keep women with underlying cardiovascular disease safe during the COVID-19 pandemic. We have 2 distinguished speakers who will be guiding us in this webinar and sharing their research with us. The first is Jennifer Heath, who is currently an Associate Professor of Medicine in the Division of Cardiology at the Center for Advanced Cardiac Care at Columbia. And she's also the co-director of the Women's Center for Cardiovascular Health at Columbia. Dr. Heath specializes in pulmonary hypertension, heart failure, and cardiac transplant. She has a special interest in chronic thromboembolic pulmonary hypertension and the care of pregnant women with cardiovascular diseases. We're also very fortunate to have with us Dr. Prabhakaran Dorairaj. Professor Dorairaj is the Vice President of Research and Policy at the Public Health Foundation of India and the Executive Director of the Center for Chronic Disease Control in Delhi. He's also a Professor of Epidemiology at the London School of Hygiene and Tropical Medicine. A cardiologist and epidemiologist by training, Professor Prabhakaran's work spans from mechanistic research to understanding the causes for increased propensity of cardiovascular diseases among Indians, to developing translational research and human resource development. Professor Prabhakaran is a fellow of the Royal College of Physicians in the UK. He's a fellow of the National Academy of Sciences in India and an adjunct professor at Emory University. He was listed as the topmost researcher in medicine in India in terms of publications, for 3 years by Scopus and the Department of Science and Technology, Government of India. Moderating this distinguished panel is Dr. Sonia Tolani, who is the co-director of the Women's Heart Center at Columbia University and is a part of the Columbia Doctors Hypertension Center. Dr. Tolani's areas of expertise include consultative cardiology, preventive medicine, and women's health. She has spent several years studying the interplay of cholesterol and inflammation and how this interaction impacts atherosclerosis. In addition to being a full-time clinician, she frequently appears in local and national media as an expert on preventative cardiology and women's health. She also actively donates her time to community outreach programs aimed at educating women on the signs and symptoms of cardiovascular disease. Please join me in welcoming all three of them, and over to you, Dr. Tolani.
Thank you, Ravina. So I'm going to jump right in since we have a somewhat short amount of time to cover this very expansive and important topic. You know, as Ravina alluded to, there are already some challenges during non-pandemic times in providing good cardiovascular and preventative care to women, both from, you know, on a systemic level on how to reach patients and also, you know, from a clinical aspect. So perhaps we can start with Dr. Heath, and you can tell me some of the challenges in our American system, and then we'll ask the same question of Dr. Prabhakaran as well.
Thank you so much for having me, and thank you, Sonia. So I think that, you know, in our culture, cardiovascular disease has been very much a man's disease. In the media, in literature, in music, whatever it is, we hear about men dying of heart attacks. There's very few stories about women having heart attacks or seeing in movies women having heart attacks. And so I think that starting right off the bat, there's a feeling where women are embarrassed if they have heart disease because they feel like it's a man's disease and that somehow it shouldn't be something that they're getting. And there's an association between heart disease and being overweight, being a smoker, being someone who sits on the couch and does no exercise. And so I think part of the challenge has been to educate women. You know, women in this country really think breast cancer is the #1 cause of death for them. And we have to try to explain to them that while breast cancer is very important and they should be screened, that, you know, cardiovascular disease accounts for more deaths in women than all cancers combined. And we have found through numerous, you know, research studies that women don't know that cardiovascular disease is their biggest risk, that they're embarrassed to talk about cardiovascular disease, that they feel embarrassed to go to the doctor and be told that they're overweight. They even avoid the physician sometimes. So, you know, that's one of the big challenges. Another we find is that women tend to seek medical care in this country when they are in their childbearing years. So they will see, you know, an obstetric gynecologist for maybe their pap smears or breast exams and for childbearing. And then there's this big lag in when women seek care again. And so, you know, that's one of the places that we've also tried to intervene, is to explain to women and try to sort of rope in our OBGYN colleagues here to say that this is an important opportunity to screen women for cardiovascular risk factors, to put into place systems to try to follow them over time so that that period of, you know, age 40 until 60 doesn't get lost, because there's so much opportunity there to intervene, treating hypertension, diabetes, cholesterol, so that we don't see the effects of cardiovascular disease down the road.
Dr. Prabhakaran, are these things that you have seen mirrored in India? Or are there some unique issues that you think are involved in the disparities of care for women there?
Thank you, Sonia, for having me on this webinar and to address this important topic. I think it's fundamentally similar across the world. I mean, there are not too many differences in terms of, if you talk to cardiologists here in the country, as to why women have the issue of cardiovascular disease in women is not addressed. They will come up with the same precise reasons. They'll say that cardiovascular disease is not an important problem in women, it's a disease of the men. That's number one. Number two is, routinely cardiovascular disease diagnosis is missed because women have atypical presentation. I mean, when you look for classical symptoms of a heart attack, you don't find it in women. They come with weakness, they come with breathlessness, they come with fainting spells, they have other symptoms, back pain, so on and so forth. So that is generally missed because physicians are looking for classical symptoms of heart attacks. Second is there is a poor awareness both amongst women as well as healthcare providers. Amongst women, it's been ingrained into them saying that, you know, heart attack or heart disease is generally a disease of men and not women, despite having many examples of women who have suffered a heart attack. Then there are some issues in relation to diagnostic challenges, particularly in terms of ECG, because many women have non-specific ECG changes, and even if they have something real, they're generally dismissed as non-specific. And so we need to educate physicians about that. The other issue is, I was on a panel a few years back on screening for hypertension, and one of the most prominent physicians said, the question that was asked by a woman journalist was, do women have higher chance of having hypertension? And I was shocked at the answer that he gave. He said, you know, women actually attend kitty parties and eat a lot of samosas which have salt. I mean, I was shocked at that kind of an answer. So that kind of a stereotyping is also there amongst many physicians. And I think it is both a problem in terms of understanding the illness amongst women. Second is lack of awareness. And third challenge is, of course, the access to the health system, which is pretty poor for women. Women generally do not like to come to the hospital. They come late. They generally try and avoid, because they have several responsibilities at home, and therefore they kind of delay coming to the hospital, and they come at late stages. So these are some of the reasons and some of the similarities and differences. One fundamental difference between the US and India may be that diabetes is much more widely prevalent. There is hypertriglyceridemia amongst women here, little more than I think what they find in US. And smoking is much lower. Alcohol consumption is lower. So that may be a little protective phenomena here.
So, you know, I think what I'm hearing and what we've seen in our work and echoing in India is that there's a lack of awareness both on the side of women patients and providers about the importance of cardiovascular disease. There are disparities in the way that women are treated both on a preventative level and when they actually come presenting with symptoms, and that there's ultimately, you know, disparities in care on probably multiple other levels that are involved with access and utilization of the healthcare system for women. So all of those things, I think, for multiple demographics in the setting of the COVID pandemic have clearly been exposed. Obviously here in the United States, we're seeing the disparity on the level of race and the higher levels of African-American and Hispanic patients with COVID having worse outcomes and higher levels of deaths, and the demographics and socioeconomic impacts of access to care. You know, that's a completely different topic, but I'm wondering if you can sort of talk a little bit about how both in clinical practice and systemic care for women has been changed in these last few months as we're in this global pandemic.
Our experience in New York, and certainly in this country, is that, you know, women make up a huge percentage of the healthcare workforce, right? So women have been called to, you know, take up frontline healthcare position work in terms of nursing and healthcare, other kind of provider care in the hospital. So the exposure of women has been high here. Our research has shown that women are less likely to die from COVID and are less likely to have severe illness from COVID and less likely to be hospitalized. There's some questions there whether that's an inherent sort of genetic predisposition that women have stronger immune systems, and there's a variety of reasons that people are trying to invoke for why that may be, and is known to be true in other infectious diseases. that we have a stronger immune system against these types of viruses. But I think that there's a lot of challenges with women getting care because they have to balance healthcare roles, caregiver roles. They also have high exposure to illness in the home. So when family members get ill with COVID, they are expected to be the ones providing care. And so, in general, we're seeing a huge loss of patient visits in terms of trying to get patients in and take care of their other medical problems during this pandemic. And I think that that's something that we're going to see down the road is the aftermath of lack of care to women and men, frankly, for the last 3 months, and what that means in terms of death. I mean, I know that there's been a lot of research showing that the rates of acute MI have been down. Is it really that there's less acute MI, or is it just that people are dying at home of an acute MI or suffering at home from the effects of that because they were scared to come to the hospital? And so these are all things that we're going to have to tackle later. And I think that for women in particular, there's been a huge struggle between caring at home, providing education to their children with schools closed, and also balancing their work life and the safety of returning home to their children. So that's, been a challenge. We've been using telehealth here. Luckily, our system at Columbia was just finished in transitioning to the Epic system, which allowed us very rapidly to start doing tele visits. We can talk more about how I think tele visits will be very helpful for women down the road in terms of being able to give them the opportunity to see a physician and talk about their symptoms without having to come to the hospital and take time off of work or take time away from their kids. So that's a little bit of an overview of what's been happening here, at least at Columbia and in New York, and I think in a lot of the United States.
Right. So I was fortunate enough to get some empirical data from WHO. WHO sent me a report in which they have surveyed 155 countries in the third week of March. And their report suggests that health services have been completely or partially disrupted for many of the cardiovascular diseases. They estimate that nearly it's disrupted for people, close to half the people with hypertension and diabetes, and nearly a third of the people for cardiovascular emergencies. But most importantly, 2/3 of people do not have any access to cardiovascular rehabilitation because of the closure of the hospitals for COVID. So there's also a problem of reassignment of staff. There's postponement of screening and postponement of elective procedures, which can actually result in complications. We don't have data on that. The other big problem is the lack of public transport. In India, we did a registry called the CREATE registry around 10 years back, 10, 12 years back, where we found that nearly 60% of the patients were using public transport or their own private transport to come to hospitals when they had a heart attack. Now, in the absence of public transport and lockdown, I can just imagine what the situation would be, and particularly for women. It is estimated that 30%, there's 30% fewer cardiac emergencies in the health facilities, particularly in the rural area in March 2020. And I think the situation is much worse now. I've been speaking to the Cardiology Society of India, and they estimate that the number of emergencies has come down to 25 to 30%. We don't have, this is just a kind of guesswork, but the fact is that whoever is coming to the hospital is coming very sick. And I'm talking in general because this, whatever I've said, applies to women in a even more higher gradient. Already it's been mentioned how women suffer because of multiple roles that they play in terms of being caregivers for patients, and in addition to their work. So the situation of COVID is actually worsened the management of cardiovascular disease, its detection of risk factors, and also has resulted in lesser compliance, because obtaining drugs, particularly from drug test facilities in India, is kind of difficult. For people who can purchase, they can purchase, but people are getting free medicines from, say, government facilities. It's been extremely difficult. So these are some of the issues particularly affecting women during the COVID pandemic.
You know, one thing that has come up in sort of access to care, and you touched on this, is the cost of care for women. And that because women tend to globally make less than men, you know, for similar jobs, have less benefits, and, you know, the cost for care for them relatively is higher. Also in the US, and it may not be the same in India, older women are more likely to live alone, not to have partners or support. And so that also affects their ability to pay for medications and pay for care. And that's been shown that it does, you know, make women on a higher level underutilize care for cost. I'm wondering, kind of with, you know, and this wasn't on our questions, but just as we're, you know, in the US going through this, you know, the unemployment and the economic sort of fallout from the pandemic, and I'm sure in India, it's the same case. How do you think that that affects women in particular, and how do you feel like, what do you think the time frame is, or for how long we're going to sort of see this, the cost of care being an issue for accessing care?
So I think you rightly said about the cost of care. I mean, there are situations which are different in India as compared to the US. Let me give you two case studies of which we did around 10 years back, and I think that will play out much more stronger now. One was we looked at what happens to families which have a heart attack or a stroke, and what happens to the girl child, and what happens to the elderly in the house. In terms of the girl child, because there's a loss of productivity, if somebody dies young, the father dies, who's the sole bread earner, dies. So the girl child is taken out of school and you know, put into domestic. This is empirically been shown to happen. Second is, particularly some of these drugs, for example, antihypertensives, statins, antidiabetics, they are considered not really required because there are really no symptoms for these diseases. So the next thing that is likely to go in terms of rationing is these drugs. So many of these older people, particularly older women who live with families, may not be getting these drugs. So that's another problem that might happen. And I think as people return back to work and they find that themselves that they're unable to afford many of the medicines that are required for these illnesses, prevention will take a big hit, and we are likely to see more events. So we need to document that subsequently.
In addition, I think it's going to be the same problem here. I mean, obviously, there's a slightly different system set up, and I think that bias against women is different maybe in this country than it is in India, and how families would cope with the loss of a family worker who provides care. Although we do have a large immigrant population, we have a large population of undocumented citizens. We have a lot of uninsured patients to begin with. So all of that is going to just be exacerbated by COVID. Getting into a hospital now for us requires a significant amount of screening, administrative work where patients have to be screened, they have to be separated from other patients, they have to be timed accordingly in the clinic so that we minimize exposure to other people. So all of these things are now barriers to access where there already was a barrier. So I think that the long-term effects of this are going to be problematic. I think that in terms of a timeline, once we can effectively, test, have a vaccine, have a treatment, we'll start to see some of this recede. But I do feel like the aftermath of this will be pretty profound, particularly for women. And, we haven't even talked about maternal care and maternal mortality. And that's another discussion about how women have access to care, prenatal care, things that we know reduce maternal mortality that will be diminished now in the setting of COVID. And so, other than to say it's going to be a problem, I think we have to try our hardest to set up systems where we can try to reach these women and screen them appropriately.
Sorry, I just wanted to add two things. I mean, we just don't have data on rheumatic heart disease, which is a problem in many parts of India. We don't have data on pregnancy-induced hypertension, which antenatal care is is actually disrupted quite a bit. I mean, they're not getting adequate antenatal care, so detection of pregnancy-induced hypertension, gestational diabetes to be issues, and that actually leads to downstream effects both for the mother as well as the child.
So, I mean, I think one thing, and I think it would be good for both of you guys to explain maybe a little bit for people from, different countries to understand the healthcare system, particularly here in New York, where we have, city hospitals where access to care is not limited by your insurance or socioeconomic status. And then we have private hospitals that, do take all comers, but tend to be better resourced, sort of systemically better funded, and they're businesses, so they really function as their own entities. And some of our hospitals that are city hospitals tend to be situated in the neighborhoods and areas of the city where socioeconomic levels are low, where they're higher levels of immigrants, African Americans, Latinos, and our Asian populations, and they tend to have been the ones, the areas in New York that were hardest hit, and I think where people had sort of poorer outcomes. There was a lot of sort of disparity in the amount of staffing, PPE, support that these hospitals were getting versus other hospitals that are sort of in our quote unquote private system, and I think that being sort of highlighted may be a good thing and may lead to some change. I'm wondering, and particularly women in these neighborhoods, who are having access to care issues primarily because of these same disparities that sort of came to light with the pandemic. How you think sort of the unveiling and sort of making this so obvious to everybody may change things in a post-COVID world for access to care and for preventative care for women and for, prenatal care and postnatal care and, all of these things that we're talking about?
I think that obviously, unfortunately, you're right that city hospitals have much fewer resources, provide care to uninsured patients, but the follow-up and the follow-through is very slim, not out of lack of desire, but out of lack of actual ability to do it and carry it out from a resource perspective. I think that there has been a lot of attention, particularly now, there's so much going on in our country related to race, and knowing there is a huge racial disparity when it comes to multiple levels of healthcare, not only in COVID and the experience we've had with COVID in terms of much higher rates of minorities dying of COVID, being infected with COVID, having more severe illness. But we already knew that the United States has a much higher maternal mortality rate than the rest of the, first world countries that are, on par with what we provide for healthcare, and predominantly affects African American women. So there are real racial disparities here, and I don't think it can be attributed to just socioeconomic status. They've done really interesting work looking at the effects of racism on the healthcare delivery for women, and that women who are African American in this country have much higher rates of maternal morbidity and mortality, even when controlling for all socioeconomic and educational factors. So the stress of racism itself has a huge impact on how pregnancies go, preterm labor, and then this is sort of passed on, this trauma in an epigenetic way to children of immigrants that come from other countries, so that we're seeing first and second generation children of these people born having much higher preterm labor, pregnancy loss, complications in pregnancy than their mothers did in their country of origin. And so, I hope that there will be a huge effort to try and minimize this. We do things in this country, in certain states, have maternal mortality review boards where we try to look at every single maternal death and try to understand what the cause was. We know that cardiovascular disease is now the #1 cause of death for women in this country in pregnancy. whereas it used to be postpartum hemorrhage. So there's been a shift. Women are having children older. They're have more risk factors when they get pregnant. There's more obesity. There's more hypertension. And so, states like California that have adopted these review boards where they look and try to understand what level did the system fail this woman, what could have been done differently. They have seen a dramatic decrease in their maternal mortality. And so I think it's very important, the Congress passed the Maternal Death Act and 2 years ago, and there's been a shift of resources into trying to preserve maternal care here. But I think that around the world, access to prenatal care is bad. And I think the biggest challenge, and I'm not sure if I'm right saying this, I know in Africa, for instance, is, distance to travel to get prenatal care and, access to doctors and hospitals. So again, the awareness is starting to be there. Now we have to put that awareness into action and make real change.
Right. I think the issues are somewhat similar, but somewhat different too. One thing that we have learned from the COVID epidemic is that the public health is in shambles, and I think we require much more investment, much more resources in terms of strengthening public health, and that will make a big change both for non-communicable diseases as well as reproductive and child health and infectious diseases. I think one thing which we have to realize is prevention of cardiovascular disease needs a life course approach. Undernourishment of maternal undernourishment, maternal undernutrition, early life undernutrition can lead to higher risk of hypertension, diabetes, and coronary artery disease, which has been shown in many studies, the famous of which is the Dutch winter hunger cohort, but several other studies have shown that if you don't give a balanced diet and if you don't take care of the micronutrient intake of the mother during pregnancy, the chances of the fetus having, when they grow into adulthood, having any of these diseases is high. So I think it's very important that we address the nutrition issue for the mothers. The second is, I think prevention is very important. Non-personal policy interventions that are required, which maybe in the post-COVID era I'm talking about. I think important areas are health promotion, providing an enabling environment, reducing air pollution, improving in the smart cities plan, improving urban built environment. So see, these are some of the issues that needs to be addressed. But coming back to the health system, which is the current focus of our discussion, I think there are a few things that need to be done. One is, I think we require some of these simple drugs. They should be made essential drugs and should be made available to at least 90% of the population. 10% may be able to afford, or 20% may be able to afford to purchase these drugs. The second is universal health coverage, which is there in India for 40% of the population for emergencies, needs to be expanded. And I think one area that we need to work on, which we have looked at in terms of research, is the role of task shifting, task sharing, and role defining. So some of the tasks which doctors can undertake can be undertaken by community health workers, pharmacists, nurses, and every non-physician healthcare provider possibly. And that actually improves the quality of care, and that we should take steps in doing that. And I think people have been talking about telemedicine and telehealth. Those are areas that need to be explored. But in India, telemedicine and telehealth access is going to be limited to a few people. So I think we require a blended approach where we have people who may visit, who are trained in identifying problems, who may visit people and then contact the doctor through a telehealth platform. We also need a novel supply chain and dispensing approaches. We need triaging to identify patients, reclassify patients based on COVID vulnerability. And while we make plans for returning back to so-called normalcy, we have to have NCDs and particularly cardiovascular disease in our framework when we decide what needs to be done. We need protocols to define those. And finally, I think we need financial protection for individuals who get into these acute problems. I think these are a broad sweep of what can be done.
We're getting some of these questions and some of these, are pertinent to what we're talking about. And Dr. Prabhakaran, you somewhat answered this, And maybe you can expound a little bit. One of the participants had a question particularly about the rural population in India. And I think you mentioned that the barriers being sort of access to telemedicine, and, you know, distance to travel to healthcare systems. You know, you mentioned a little bit using sort of trained healthcare workers. Are there other public health approaches that may address the issue of preventative care for women in these areas that make up such a huge portion of Indians?
So one of the frameworks which the government decided was the health and wellness clinics. So they had proposed to have around 25,000 health and wellness clinics in these villages and the remote rural populations, basically to convert the primary healthcare centers and the sub-centers to cater to the wellness of the population, in which health promotion was a major component. And I think we require skilling of people within the local communities, actually. When you cannot, export people there and ask them to work there, we need skilling of the local population. And that's where one of the largest capacity building efforts needs to be there, that you have these, I don't know whether you're aware of an entity called the ASHA, Accredited Social Health Activists. So we require an ASHA equivalent for non-communicable diseases who could do some of these simple tasks in terms of screening people for tobacco use, for alcohol use, in terms of giving dietary advice, measuring blood pressure, with a point of care device, measuring blood sugar, so on and so forth, and actually creating a cardiovascular risk profile, in addition to providing advice on physical activity and so on and so forth. So that's one of the areas that requires attention. The second area is, let us identify 10 or 15 simple drugs, like a single antihypertensive, which is not very expensive, anti-diabetic, which is not very expensive, make it available throughout the year. Many times it's there in the Indian public health system. It is a recommended thing in the public health system, but it's not available throughout the year, and patients go off drugs. So I think we require to do that. The third is use technology. Use e-pharmacy, for example, because stockouts occur frequently if you rely on human beings. So basically have a e-pharmacy kind of system. Whenever there is a shortage is likely to occur, we can replenish it soon. And you require innovations in terms of delivering these drugs to people. It takes almost 1 day for a person to travel from his village to come to the PHC, for a lady to come to the PHC and go back. So can we have an innovative way of delivering these drugs at the doorstep? So these are some of the things that we really require to look at in the rural setting. The rural population, though, as somebody in the question said that they have high risk of coronary artery disease, actually have somewhere between half to a little bit considerably lesser prevalence of risk factors, and we have to protect them. The problem is when they migrate to the cities, they acquire urban level risk factors very rapidly. So clearly, it's a larger issue in terms of providing employment, in terms of making them comfortable where they are, and in terms of providing them care. But some things which can be done in health system are important. That is task shifting, make drug distribution easy, and make it available. I think these are the three things essentially that we need to do.
Jen, another question sort of on very similar, I think obviously the disparities in access to care in India and the US are vast. I think there are parts of rural America where, not to the same extreme, but there is an inability to access preventative care. There are not hospitals nearby that can provide higher level cardiovascular care, such as coronary artery intervention, et cetera. You had mentioned sort of telemedicine as a way to reach women during this COVID crisis, and that might be something that moving forward is a way to continue to provide care. What do you think about also, what Dr. Prabhakaran is saying about sort of using other healthcare workers or community members? There was a study here, the barbershop study in the United States, that showed that African-American men, when their a place that they go is the barber shop. And when the barber in a community who's a sort of trusted community member was involved in the care of hypertension, their control was much better than the people who were going to the doctor, you know? So how can we sort of, especially, and maybe you can both comment on this, in an era where people who even have access to medical care are afraid to go to clinics and hospitals, how can we sort of utilize this? And one of the other questions was like, what are some of the things you can like direct women to do at home to help them personally evaluate their risk, or if there's an issue with heart disease that would need them to seek higher level care?
Yeah, I mean, obviously, even in our rural communities, we have trouble reaching patients and helping. So if there was some system in place where we could go out and have, you know, teams of people that are dedicated to providing and educating people in those more rural communities. And again, like Dr. Prabhakaran said, like providing medical therapies. One thing, you know, we know is that there's always a reluctance to take medication, whether it's somebody who's educated or not educated. I think that people, I mean, even if you're given a course of antibiotics for strep throat, you know, many highly educated, you know, highly plugged into the medical system people don't even finish their 7 days because they're sick of taking it or they think they're better. And then can you imagine asking people to take a multi-drug regimen? And so compliance is huge. So if we can try to reach out, you know, enhance compliance, like you were saying with the barbershop study, find community leaders who can help reassure patients when patients are discharged from the hospital, instead of writing a prescription for, you know, a statin and an aspirin and a beta blocker, give them those medicines in preformed packs for, you know, a 3-month supply with a follow-up call in 7 days and a follow-up visit. I mean, obviously this works better in areas that have hospital centers and clinics where people can follow up. But I do think that traditionally, you know, the medical system has felt like, well, it's up to you to follow up. We gave you an appointment and you didn't show up. And I think we have to do better than that. You know, we have to say we gave you an appointment in 7 days. And when they don't show up in 7 days, we call them, or we call them to remind them. In terms of telehealth, I know that there's been a lot of, now that, you know, in this country, telehealth took off in a way that it wouldn't have been able to before COVID because of regulatory issues. But now that, you know, doctors feel like they can bill and be reimbursed, telehealth is working. And then there's this question of, well, should we provide preformed packs to people? You know, should that be part of your insurance? Should that be a government outreach where every patient gets a blood pressure cuff, you know, a pulse oximeter, you know, some kind of a scale, right? So these basic things that probably don't cost all that much money, you know, when you look at it compared to the huge amount of medical costs downstream if people aren't taking care of themselves. And if patients receive this package of a scale, a blood pressure cuff, and then they have a visit with the doctor, or a tele visit, or even a phone call with the doctor, can we enhance compliance and trust between physicians and patients? Also, I think it's really crucial that we have more minority providers, right? So I am, you know, a white woman in New York City, but if I was a African-American woman in a rural part of this country, would I trust a white male doctor, or would I feel more comfortable with an African-American doctor or nurse practitioner? And so that's also important, is that we make sure that we have a lot of diversity in our medical system so that we minimize, you know, lack of interest and enhance being able to relate to the person who's taking care of you. So, I mean, those are some areas I think where telehealth and access to care come into play. We obviously don't have universal health care. This is an ongoing debate in this country. If everyone could have some baseline universal health care, would we clearly see benefit to public health? Yes, but that is something that has to change on such a fundamental level in this country. It's going to be, you know, based on who we vote for and and who gets elected into Congress and president, you know.
So I would agree with some of the things that you said that can be applicable to an urban upper middle class population. I mean, it may be easy for them to get a wearable device for surveillance, a point of care device as a diagnostic tool. So those things are possible. I mean, any number of softwares are there in terms of what they can do for their diet and physical activity. But what do you do to the vast swath of women who actually work? Like just to give the example of Mumbai, there are a lot of women who travel in the train, get up very early in the morning, cook for the family, then get onto the train. And while coming back, they actually do some of the work that they have to do in the house. They cut vegetables and bring them and cook. So they hardly have any time for any of these screening measures. So I think one innovation that we can think of in terms of therapeutics is to look at polypill as a method, because it's a single pill combination of multiple drugs for cardiovascular disease. And we have shown compliance to be at least 33% higher with a polypill. It's being evaluated for primary prevention, but for at least people with established heart disease, it may be the way to go, because people tend to forget to take these medicines. Second, I think one area which I want to touch upon is like, for example, we tell people to walk. Where is the sidewalk to walk? It's occupied by hawkers, it's occupied by vehicles. And there are parks and parks, but people don't use parks. In an empirical study that we did and published, is one thing which makes a big difference is a huge park in the community. If you have small parks, it's taken away by the gated communities, or it's used for criminal activities. Large parks gives equity, and it shows that people who are closer to that large parks, irrespective of the socioeconomic status, their mental health status is better, their blood pressure is better. So these are some of the things we need to look at when we are planning the cities. Then taxation of some of the products, like cigarettes are taxed. Maybe we need some more health promotion material in terms of the warning signals on the cigarette packet. So these are some of the things that can be done. In terms of the sugar sweetened beverages which are used by children and others, again, taxation may be of help. So there are some measures which the government can take in terms of reducing, but I think there are a lot of things, really a lot of things that we can and we need to do in rural areas. And the biggest person who can actually make it happen is that community health worker. He or she is the bridge between the community and the health system, getting people to the health system, helping them with getting the drugs. And the drugs are provided on a monthly basis. Earlier it used to be provided on a weekly basis. Now I think providing it for 3 months, it may be a good idea, or somebody getting it to them every month may be another idea. So these are some of the innovations that may be required.
So some of these questions are coming in, and I do want to get to them before we end, but sort of to close up our sort of more focused discussion on COVID and how it affects our care for women. We're now in New York, and I don't think quite in India at a nadir, and our clinics are opening. We're getting back to some more elective care procedures, but all of us, at least in the healthcare community, are nervously awaiting a second wave. I think without a vaccine and a clear treatment, it's hard to, rest easy. I'm wondering, what you think sort of on a systemic level, planning for the fall, planning for, a case where we do get a resurgence. What sort of changes do you think we need to implement before, to prepare for that possible second wave?
Well, I guess in India, they're still on their first wave. But in here, yes, I mean, we're at a nadir. I think that, what we had to do in a scrambling format when this hit, I think we're lucky enough to now have a framework to know what worked and what didn't work. In my group, where we do advanced heart failure, and we have a very patient-based population. We have a lot of patients on LVADs and patients with heart transplants. We were able to quickly pivot, and a huge number of outreach phone calls to patients, a huge number of tele visits provided, trying to isolate very sick patients to bring them in when needed in COVID-free areas. I think there needs to be a clear demarcation of non-COVID and COVID areas in the hospital, which we did at one point there was the COVID-free areas were very small because almost their entire hospital was COVID. But so I think that we need to make sure that our patients understand that they still need to come to the emergency room if there's a real problem, and not be afraid that we have things in place to protect them when they're here, and that our rate of transmission to healthcare workers and to patients was very, very low once we adopted good PPE. So a lot of that has been pre-established, and whether we'll have to shift quickly into that again, remains to be seen. I think that patients really appreciated how much we reached out to them. I think we shifted our transplant patients quickly, where we did blood work to, partnered with companies that, look for rejection and blood work as opposed to having them come in for biopsies. I mean, obviously none of this is ideal, and it won't be ideal in a pandemic, but I think it's going to require that the hospitals be prepared to manage the patients, that the doctors and nurses and PAs and everyone who works in the healthcare facility be prepared to be, redistributed to different teams, that it's essential to have an outpatient team that's devoted to calling patients, checking in, making sure they have their medications, and hope for the best, I think, in terms of how we can keep COVID under control for the next 6 months.
So I would kind of agree with you on whatever you said, but I think one thing for India is we have learnings from two levels. One, what happened in the US, Italy, or other countries. And second is our own learning within our health system as to what is happening. I think there are a lot of learnings in terms of what, when we look at the second wave and what can be done. I think one of the things what we have not done and what most countries have not done is to look at what are the excess deaths, excess non-COVID deaths that has happened because of not providing treatment for people with existing diseases or people with cancer, or dialysis is a big problem. People don't have access to dialysis because of transport issues. So they may have died. So what are the excess deaths? And how do we actually streamline care for COVID and non-COVID patients? That's one of the things that we need to work for. The second is, as patients come into hospital, I think we need a safe triaging mechanism into streamlining them into COVID care and non-COVID care. And I think we would have learned enough by now to do that. Third, I think, is when I was a medical student, we used to be told that if you know tuberculosis or if you know diabetes, you know medicine as a whole. But I think COVID is teaching us a whole range of things about medicine, starting from pneumonia to pulmonary embolism to stroke to several things. And in fact, from the early stages where we thought ventilators were the panacea, now we know that it is oxygen which is important. So a lot of new things come up. Third, we have to be nimble enough. If for example, we find some drug to be useful, how do we produce it on scale as a generic? I mean, that is one of the things that we need to think of. And as we are working on vaccine, maybe we do get some vaccine by end of the year or early next year to cater to this problem. But in terms of the health system preparedness, both in terms of human resource and apportioning their work correctly in terms of, I mean, every member of the healthcare system will be important, including people who clean the wards to the highest administrator in the hospital. Each one has a specific role, and maybe protocols need to be devised in terms of defining their roles. We also need protocols in terms of how to handle the situation. There are protocols now, but I think we have to be dynamic enough to modify them. I think these are some of the things at a larger level that requires to be done when we are anticipating this second wave.
I think those are all great ideas. I think we've sort of covered a lot of what we've learned from this pandemic is that the disparities that we knew were there have been highlighted. The preventative care and care for women that was already flawed and difficult to come by has gotten worse. But that the lessons that we're learning is that, in learning how to deal with the pandemic and getting care to people that don't normally access care, perhaps we can utilize those once this is over to provide, better preventative care and cardiovascular care to communities and populations, particularly women who didn't have access before. So perhaps there is some sort of silver lining in changing our healthcare system to be a little bit more flexible to offer that level of care. I want to switch over to some of the questions that we're getting from our participants. And a lot of these are touching on the idea of medical education. and how we get, I think we've seen, even as this pandemic is going on, people relying on social media, Twitter, Facebook, WhatsApp to get information that is not always properly vetted. I'm sure we all received messages from family members saying, like, the new way to cure COVID is just to gargle hot water, and, all these things that are out there, so, and I think for some time that has been how people, particularly women, have accessed care. So maybe you can talk a little bit about, how do we improve medical education? How do we allow women to better understand that they're at risk? 90% of heart disease can be prevented by controlling risk factors. So how do we get women to know about their risk factors and self-evaluate risk factors? What are some of the things that you envision us being able to do with that?
One thing that's interesting is that in this country now, like more than half of medical school classes are women. And so I think that that's going to make a big difference as more women are physicians in the future. I think that there's a huge push for education and awareness on social media about women and heart disease. We've had lots of campaigns here, Red Dress Campaign, the American Heart Association, people telling their stories in the media. And so, that is a huge help, because I think that, there is so much connection to social media now. I think that, we need to educate people in medical school classes and in residency. We need to have electives in women and cardiovascular disease. We need to educate our OBGYNs, since they are frontline to women. And that's become a huge benefit in the last year, as our collaboration with the obstetrics world, and how they are now aware that, they need to check blood pressure, they need to check cholesterol, as that may be a woman's only visit for, many years in childbearing age. We know that we now have to educate women that, severe preeclampsia is a risk factor for heart disease later, that preterm labor is a risk factor, that there's a lot of female specific risk factors that we are now learning that we need to share with the community. So that's, one thing is, one is social outreach, two is, creating electives and education programs. I think there was a study a few years back that showed that, a huge percentage of even cardiology fellows didn't realize that cardiovascular disease was the #1 risk factor for women, let alone primary care doctors. So, we're failing as a medical community and educating our own people. So that's, another, we're having symposium. We have our Women in Heart Disease Symposium every year, except this year for the last 6 years, to try to educate doctors, providers in the community. I guess from my perspective, those are the big interventions that we can make.
Right. I think, let me think of education at multiple levels: education of individuals in terms of what is healthy and what is not healthy, education of the community, education of the healthcare providers, medical students, doctors, primary care physicians, and even cardiologists, and policymakers. I think education is multi-layered, and we require different strategies at different levels. And at Public Health Foundation of India, we are working on all those aspects. And we do have a primary care physician training course for management of various diseases. We also have developed electronic decision support systems for management of several chronic diseases, and we are actually moving on to develop decision support systems for management of reproductive and child health. So that's one aspect. But one innovation I would like to speak of is, as we are all aware of the World Hypertension Day, which used to fall on the 16th of May. But over the last 3 years, what we have done in collaboration with the International Society of Hypertension is to have a May measurement month where we screen people for hypertension over the month of May, from 1st of May to 31st of May. And with a very, very simple technique at low cost. For example, in the last 3 years, we have screened close to 900,000 people in India and around 2.5 million people in the world. So it is a perfect example of how you use resources, volunteers, simple tools to create that awareness about hypertension. And we need to focus on one or two simple disease. Hypertension is the leading killer, actually. It causes, it's responsible for 10% of the mortality worldwide. And if we tackle hypertension, and similarly, we take up some other example, maybe breast cancer as an example, or tobacco use as an example, and focus on a few issues, but go in a big bang way to provide that education to the community. We would have created the awareness. At least it takes away people from learning from the WhatsApp universities.
Well, thank you. And maybe in just a minute or two, if there's any final thoughts that you have, I want to thank you both for this. Very obviously, an hour to discuss this vast topic seems very short, but I think we were able to touch on a lot of very important issues that have been highlighted by the pandemic that we're in right now. Do you have any final thoughts about cardiovascular disease for women? Thoughts for the future, hopes, concerns?
I mean, I feel like just having been part of this session, I think that the more you engage in groups like this and hear from insights from other people that you don't normally get to speak to is very inspiring and motivating. Hearing Professor Prabhakaran's, ideas and thoughts about what, he does in India and what they're doing in India, and then how I could, implement some of those ideas here and getting engaged with your community. These kinds of exposing yourself to these kinds of educational groups and meetings is inspiring, and I think that people may be reluctant to do it or they're busy, but then when they do it, they get a new idea, and then that idea leads to something else and something else. And so I think that it's really important to stay engaged with your community, learn, pick up things that you hear, and then when you get excited about it, act on it, because you really can make a difference.
Right. I just have three very simple messages. Number one, I think we have to emphasize the fact that cardiovascular disease is a leading cause of death in women too. It's not a disease of men alone. That's number one. Number two is prevention can actually reduce cardiovascular disease. In one generation in the United Kingdom, where cardiovascular disease was the leading cause of death in 60s, has fallen by 50%. And I think it is become the number 2 cause or something like that in UK. So it is possible to prevent. Number 3 is it's important to identify the problem earlier and prevent it by simple lifestyle changes and drug therapy. And I think, and many generics are available. People should not get overwhelmed or frightened by this disease because it is potentially treatable. I think if we can give these three messages to people, I think we would have done our job today.
Great. Well, I want to thank all of our collaborators, the Center for Social Difference, Women Creating Change, the Columbia Global Center in Mumbai, Columbia Presbyterian, for this really wonderful discussion, and for everybody that participated. If you have questions, I can provide my email. We can send that out. Rabina can get us these questions that we weren't able to answer. So hope everybody stays safe out there today. And thank you again for taking the time to participate in this discussion.